نقدم أستاذنا العزيز الأستاذ الدكتور سمير نعيم أسعد هيتكلم عن الجلوكاجون is no longer the bad guy in the diabetes.
Allow me first to thank the organizers. Thank you, Professor Magdi Halmi, Professor Talat Abdelati for the invitation and for the whole crew. Very well organized conference. I think for the early morning Friday, it's almost very good. And actually, if you see in the old Egyptian movies, there are characters playing the guy characters, as you see. Riyad al-Asabgi, and the good character or the good guy like Ismail Yassin. And we see now in the next 15 minutes if a bad guy can be really a good guy. Let's see. And we have been taught as medical students, we are still teaching our students up till now that the main two players for glucose control are two hormones. First, glucagon released from the alpha cells, it will stimulate the production of glucose from the liver, and also most important, the production of glucose from non-glucose origin, what we call gluconeogenesis, like amino acids and alpha cells. On the other hand, when the blood glucose is high, there will be a release of insulin to decrease this is the usual balance. And both hormones are secreted by the, as you see, alpha and beta cells from the islets of the hand were actually discovered by this gentleman. He was 22 years of age from Sweden, Paul Langerhans, and he discovered the islet of Langerhans. He was only 22 at that age. This is amazing, and this is encouraging for our medical students. Some of them are really very bright. And Paul, at that time, he reported there are some cells near the pancreatic ducts. And he said, I admit frankly that I'm not able to explain the nature and function of these cells. This was in 1800. But in the early 1900s, while Banting, as you have heard, they discovered the insulin by doing experiment on the pancreas, and they discovered a certain material leading to increase in the glucose. But the term glucagon was coined by Kimball and Merlin in 1923, and they called glucagon, glucose agonist. So this is agonist to glucose. And this is, they discovered the sequence 29 amino acids in the 1950s, and this thanks to this gentleman, Professor Roger Unger. He lived up, and he passed away 5 years ago, and he got a lot of publication. And he discovered the sequence and how to measure this hormone. Myself, my history with glucagon was 40 years ago when I was doing my PhD thesis. This is a joint work between University of Alexandria and University of Texas. And we did discover that the patient with chronic liver disease. As you see, this is patient with cystosome and hepatic fibrosis in the old days, in 1980s. And you see in the black box curve, this is our patient with cystosome and hepatic fibrosis. There was impaired glucose tolerance in comparison to those with the white boxes. So there was impaired glucose tolerance. And for the first time, we did describe that this entity is related to high glucagon. And glucagon measurement at that time was really very, very, very difficult. We spent hours in the lab to measure it. And actually, this was published in Metabolism from USA in 1990, showing that glucagon is important for what we call diabetogenic liver disease. On the other hand, I had some publication with glucagon secreting tumors, again in the American Journal of Medicine. This was my introduction to glucagon in the 40 years ago. But recently, in the last 10 years, glucagon has been shown to be related to type 1 diabetes. You see that after the 5th year of type 1 diabetes and type 2 diabetes, you can see this is type 1 and this is the curve. It's going up. The glucagon goes up with the duration of diabetes. On the other hand, also type 2 diabetes patients, they do have glucagon. As you see that on the left side, that this is the glucagon measured after oral glucose, and some of these patients, they do not suppress. Normally, with the white circles, they do suppress. In the black boxes, those patients not suppressed, and those patients are having a high glucose. On the other hand, very interesting also, that the alpha cell mass was increased in type 2 diabetes. What about impaired glucose tolerance test, pre-diabetes? Again, in the curve red line, you can see this is the glucagon after intake of glucose. Normally, after you take glucose, glucagon goes down. But in patients with impaired glucose tolerance test, the red curve, they do not go down as normal. So it means that glucagon was high even in patients with IGT. This drew attention to different scientists that you can give what we call glucagon antagonist to improve the diabetes. And actually, different drugs have been available, not commercially available, that showed that the take of glucagon antagonist, there is drop of the blood glucose, and this is expected. But strange enough, the body went up, the lipids went up, and the liver enzymes went up by taking this glucagon antagonist. And that's why this group was already banned. Nobody thinks about that. But the strange thing that the alpha cells will secrete glucagon. Glucagon has got a lot of physiologic effect. This has been known in the last 10 years again. We not only glucose production from the liver, you can see on the left side, diminished food intake by glucagon, increased insulin secretion by glucagon, the excessive energy expenditure on the effect on brown tissue, and also important is stimulation of contractility and a little bit of increase in the heart rate, remember that. And also in the liver, not only glucose overproduction effect, but also the glucagon is important to diminish the lipid production in the liver, and this is very important part. But actually the calorogenic effect of glucagon was known 1957, but nobody thought about that. This was only from the last 10 years they discovered that glucagon has got other effects apart from producing glucose from the liver. And the effect of glucose on energy expenditure now is well settled by acting on the brown adipose tissue, white adipose tissue, and the liver. It diminishes it increases the lipid oxidation, and also it stimulates the calorogenic effect by the uncoupling protein. And you can see this is very important to increase the energy expenditure. And this is actually one of the important medications. Most of these, your patient come, doctor, I need something to increase my energy expenditure. The glucagon, this is the good guy. And that's why they have banned, as you see on the left side, the glucagon antagonist. They are now thinking glucagon agonist. But not only alone, because say alone it will increase glucose. They need to put it with something like GLP-1 or GIP-1 in order to hinder the glucose increase. And that's why they added this group of medication to effect on GLP-1. I've got two to remember. On the left side, the dual agonist, GLP-1, acting on, this is one molecule, acting on GLP-1 receptor and on glucagon receptor, called the main one is sulfatide. And on the right side, the triple agonist, acting, stimulating the GIP receptors, GLP-1 receptor, and also glucagon, like the retaglutide. And these two medications are about to be, now they're in phase 3. They are about to be available for us to use it in 1 year, inshallah. And the sulfaglutide is acting, as you see, it's one molecule acting on the two receptors, and amazing results. On the left side, you can see 15% drop by the maximum dose, which is 4.8 milligram. 15% drop in the body weight. And also in patients with diabetes, of course, as expected, the drop in body weight is not as those with non-diabetic. It went down to 9%. But again, you see on the right side, there was a diminution of hemoglobin A1C by 1.9. This is very good. And another angle is the effect on the liver. Remember, glucagon, it leads to reduction in hepatic lipid accumulation. But also it does have a very important effect. It reduces the stellate activation, thus reducing fibrosis. That's why they did very interesting phase 2 study, the effect on MASH of survodutide, and this was a 48-week. They used 4 doses, 2.4, 4.8, and 6, and placebo, 4 arms. And they have chosen patients with documented by biopsy of MASH. Of course, F1, F2, F3, not F4. They don't use F4 in research. And you can see the results again. 62% improvement in the MASH with no worsening of fibrosis. And moreover, fat reduction by 67%. But this drug, I think this is for fatty liver, this is the future for fatty liver, or the so-called fatty liver. So in resume, survodutide activates GLP-1 and glucagon. It's injectable every week subcutaneously, and it shows very good results, 19% reduction in the body, up to 19% reduction in the body weight. But there are stage 3 synchronized study going now, be finished in a year, inshallah, and expected to be released. Inshallah, there is a very good percent, over 80% of people, there is improvement in the metabolic associated steatohepatitis, the fatty liver of all time. They're doing also a cardiovascular study, cardiovascular. This was started a few months ago with this drug. We have to wait. The third, or the second, is acting on 3 molecules. This is the GLP-1, GIP, glucagon, the triple agonist. And we call that the retaglutide, acting 1 molecule, acting on 3 receptors. And you can see, again, the results in this phase 2 on more than 300 patients, about 24% more than the tirzepatide. And you can see that there is no plateau. They did that for almost 1 year, but we don't know if there is a plateau like other drugs. Other drugs, there is a plateau, but this we do not know. They need to do longer study. And very interesting is the relation to the percentage. You can see with the 12 milligram, 8 milligram dose, there is no non-responder. Like other GLP-1, other GLP-1, you get non-responder. But with this drug, no non-responders, 0 non-responder. And in patients with type 2 diabetes, again, there was a drop of hemoglobin A1C by 2% by this molecule. Also, the fat, there was a fat decrease. You can see the liver fat was reduced by using this triple agonist, the retaglutide. And you can see that in the retaglutide, the glucagon has got similar effect to GIP and GLP-1, similar central effect and insulin secretion. What is different? It increases energy expenditure and it diminishes fat. This is the difference between the other 2 molecules. Retaglutide, resume, is a medication, triple agonist, glucagon, GIP, and GLP-1. And you can see the very good percent, up to 24% reduction in body weight. Phase 3 studies are going now. The Triumph studies, there are 3 studies, and expect to be released in a year, inshallah, and the drug to be approved in 27, bi'iznillah. At the end, Madam Chair, ladies and gentlemen, the key message is the glucagon now is changing. You can see in the old time, it acts on the liver to stimulate glucose. Now it has got effect on the energy expenditure on the upper side, increased satiety, diminished appetite, stimulation of insulin secretion, gastric emptying. But very interesting is the effect on the kidney, the stimulation of glomerular filtration rate. So since this is really amazing. That's why at the end, the incretin-based agent, we have started by GLP-1. This was a dream for us 10 years ago. Now we're using GLP-1, everybody, with very good results, like the oral one presented nicely by our colleague, Professor Ahmed, and the long-acting available in our country, like liraglutide and semaglutide. And more recently, there was agonist, the tirzepatide, acting on GIP and GLP-1. And the glucagon came as the last and good player, and you can see that you can use it in combination acting with the GLP-1 receptors, what you call the triple retaglutide or double glucagon and GLP-1, glucagon and GLP-1. This is the survotide about to be released, inshallah. So at the end, ladies and gentlemen, really, the good guy now is there. Ismail Yassin is winning. Ismail Yassin is winning. Although Riyad al-Asabqi is both of them are in our heart. And thank you very much for your attention.